Welcome to Science Force, where science comes alive. A very warm welcome to you all. Now, did you know the average person takes over 20,000 breaths every single day? For most of us, it's completely effortless, right? We don't even think about it. But today, we are going to embark on a journey into a truly fascinating, microscopic battleground that exists right inside the human body. We are exploring asthma. It's a condition that affects millions globally, yet it's so often completely misunderstood. So whether you're someone managing the condition yourself, a curious learner, or a medical student brushing up for your exams, we're going to break down the science of it clearly, vividly, and step by step in today's explainer. Just take a deep breath with me for a second. In and out. Simple, right? But what exactly happens inside your lungs when that simple, vital act of taking your next breath suddenly becomes a battle? To really answer this, we're going to travel all the way from the macroscopic level, the breath you literally just took, straight down to the cellular level to see the magnificent and honestly sometimes turbulent mechanics of the human airway. Here is our roadmap for today. First up, we'll compare normal airways versus asthma. Second, we'll dive into the pathophysiology of asthma. Third, allergic asthma and remodeling. Fourth, recognizing symptoms and diagnosis. And finally, fifth, treatment and long-term management. Section 1. Normal airways versus asthma. Alright, let's jump right into Section 1, normal airways versus asthma. Think of a normal airway like a clean, wide-open plumbing pipe. The inner passage, which we call the lumen, is wide open. The mucosa lining is nice and thin, there's barely any mucus, and those smooth muscles wrapping around it are completely relaxed. The air just moves effortlessly. But imagine the airway of someone with asthma. This is definitely not a clean pipe. It's a blocked tube. It's chronically inflamed. The lining is swollen, it's clogged up with thick, sticky mucus, and those smooth muscles are tightly contracted. The actual space for air to pass is dramatically reduced, and that creates immense resistance. Now, I want you to draw your attention to one specific, absolutely crucial word here, reversible. You see, unlike many other chronic lung diseases that cause permanent damage right from the very start, asthma is characterized by reversible airway narrowing. The airways can actually open back up, either on their own or with medication like bronchodilators. And this simple fact gives immense hope to asthmatics worldwide. It means that taking control is entirely possible. Section 2. Pathophysiology of asthma. Moving smoothly on to Section 2, the pathophysiology of asthma. The absolute defining characteristic of asthma comes down to this one term, airway hyperresponsiveness. I want you to really master this concept. Essentially, the airways become exquisitely sensitive. An asthmatic's immune system massively overreacts to everyday things, dust mites, a bit of pollen, or even just a brisk walk in cold air, things that a normal person breathes in without a second thought. This hypersensitivity acts as the core trigger for everything that follows. When that hyper-responsive airway gets triggered, it doesn't just sit there quietly. It actually summons a microscopic cellular army. For the life science students watching, these are the key inflammatory cells infiltrating the airway wall. Eosinophils, mast cells, T helper 2 lymphocytes, macrophages, dendritic cells, and basophils. This army releases inflammatory mediators, chemicals like histamine and leukotrienes, and they are the true culprits, causing the swelling, the increased blood flow, and that thick mucus production characterizing the disease. But those chemical mediators, the histamine and leukotrienes, they do something else very specific. They cause what we call bronchoconstriction. I want you to visualize this for a second. The rings of smooth muscle wrapping around your bronchi suddenly squeeze shut, exactly like a tightened fist. This bronchospasm severely narrows the airway, causing that terrifying feeling of chest tightness and breathlessness the patients experience during an attack. Which brings us perfectly to Section 3, allergic asthma and remodeling. So you might be wondering, what exactly triggers this extreme immune reaction in the first place? Why on earth does a child's body suddenly wage war against something as totally harmless as pet dander or pollen? Medical students pay close attention to this logical sequence because it happens in three distinct phases. Sensitization. The allergen enters, antigen-presenting cells process it and activate those Th2 cells we mentioned earlier. These Th2 cells stimulate the production of IgE antibodies which bind directly to mast cells. The trap is officially set. Early phase response, re-exposure. The allergen returns, binds to the IgE on those mast cells, causing them to degranulate. They literally burst open, releasing histamine within minutes, and boom, there's your immediate bronchoconstriction. Late phase response. Several hours later, eosinophils and neutrophils arrive at the scene, sustaining a prolonged inflammation that can last for days. Now, if that inflammation goes completely untreated day after day, month after month, year after year, we start to see a very dangerous chronological progression. What starts as acute inflammation over a single day slowly leads to major structural changes over months. We get smooth muscle hypertrophy, meaning the airway muscles literally get larger, and a big increase in mucus-producing goblet cells. Over 5 years or more, this chronic state causes collagen deposition, which thickens the basement membrane and leads to fibrosis or scarring. This long-term progression is exactly what we call airway remodeling. And I absolutely have to emphasize this with utmost seriousness. Airway remodeling brings permanent architectural damage. Thicker walls, extra blood vessels, and scar tissue mean the airways completely lose their natural elasticity. Remember earlier when we said asthma was reversible? Well, if untreated inflammation leads to extensive remodeling, it can actually cause partially irreversible airflow limitation. And this right here is exactly why asthma must be proactively managed over the long term and never, ever just ignored. Alright, let's zoom back out to the big picture in section 4, recognizing symptoms and diagnosis. The everyday clinical symptoms are actually quite characteristic. You've got expiratory wheezing, which is that high-pitched whistling sound specifically when breathing out. There's shortness of breath, chest tightness, and a persistent cough that absolutely loves to wake patients up in the middle of the night. However, we must clearly separate these everyday symptoms from a truly life-threatening medical emergency known as status asthmaticus. If you or someone you know experience extreme breathlessness, the complete inability to speak in full sentences, a silent chest where practically no air is moving, or cyanosis, which is a bluish tint to the lips or nails, listen to me, this requires immediate drop-everything emergency medical intervention. To diagnose asthma objectively, doctors use a simple breathing test called spirometry to measure airflow obstruction. The two key metrics you need to know are FEV1 and FVC. FVC, forced vital capacity, the total amount of air you can forcefully blow out after taking a deep breath. FEV1, forced expiratory volume in 1 second. How much of that air you can push out in the very first second. During an asthma's DAC, because the airways are narrowed and highly resistant, that FEV1 metric drops significantly. And here is where the diagnosis is officially confirmed. If a patient does the spirometry test, gets a low FEV1 score, and then is given a bronchodilator inhaler, their airways should open right up. If a second test shows a significant improvement in that FEV1 score, the diagnosis of asthma is confirmed. This beautifully proves the reversible nature of the disease that we discussed at the very beginning of this explainer. Finally, let's look at the solutions in section 5, treatment and long-term management. This right here is the absolute most vital distinction in asthma management, understanding relievers versus controllers. It is essential for passing pharmacology exams and frankly for real-life survival. Reliever or rescue medications like salbutamol, these are for rapid relief. They relax that airway smooth muscle within minutes during an active attack. Controller medications like inhaled corticosteroids like budesonide or fluticasone, these are your daily
daily preventatives. You take them every day to suppress that underlying chronic inflammation and prevent the airway remodeling we talked about earlier. Put simply, rescue inhalers fix the immediate symptom, but controller inhalers treat the underlying disease. Now, for persistent or severe asthma, medical science has advanced beautifully over the years. We now use long-acting bronchodilators like LABAs in combination with those corticosteroids. There are oral medications like Montelukast, which specifically block those leukotrienes we saw released during the allergic reaction. And for severe, highly uncontrolled asthma, we have cutting-edge biologic therapies like omalizumab and mepolizumab, which precisely target and neutralize very specific inflammatory pathways. But its medication is only half the battle. Good asthma control requires highly active self-management. This means identifying and actively avoiding your personal triggers. It means practicing the correct inhaler technique because let's face it, the medicine only works if it actually reaches your lungs. You should be monitoring your airflow at home with a peak flow meter, religiously following a
personalized asthma action plan crafted with your doctor, and making sure to stay up to date with your annual influenza vaccinations to prevent viral exacerbations. Conclusion. Yes, it's a complex disease, but the most important takeaway for you today is this. With the appropriate treatment, trigger avoidance, and regular doctor follow-ups, most individuals with asthma can achieve excellent control and lead completely active, healthy, and perfectly normal lives. The power is entirely in your hands. So, what steps will you take today to master your airway health? Thank you so much for joining me in this explainer, and keep learning.
Thank you for watching Science Force.